So in continuation on our tutorials on mechanical ventilation, we'll look at the second aspect this evening, looking at non-invasive ventilation. For a bit of background, mechanical ventilation can be invasive or non-invasive. And those of us who were at the last tutorial, you will remember what we talked about invasive and non-invasive. So we continue this evening as we look at non-invasive ventilation. Okay. So non-invasive ventilation is a means of delivering mechanical ventilation without endotracheal intubation or tracheostomy. All right, when the patient is being supported by a mechanical device without the interface of endotracheal tube or endotracheal intubation or tracheostomy tube, it's referred to as non-invasive ventilation. All right, it was initially used for patients who are hyperventilating due to neuromuscular disorders, and it has been found to be very useful of acute respiratory failure without the complications associated with endotracheal intubation or tracheostomy. So non-invasive ventilation is a very good armamentarium to our ventilatory support for our patients, especially those who may not require invasive airway. Now, the advantages are many, but before we do that, before we go into advantages, let's look at the different interface by which non-invasive ventilation can be administered. You can do that with mask, which could be NASA mask, as you can see on the left side of the screen. NASA mask, you can do oral NASA mask, or you can have the total face, as you can see here. Other necessary adjuvants to raise that need of a pillow, a mouthpiece, and sometimes helmet. So this ventilatory support is delivered through this interface. There are a lot of advantages and disadvantages of non-invasive ventilation that we need to consider. Number one of the advantages is that it's easy to implement. Like we said, it does not require endotracheal intubation or a surgical airway. You know, it affords for patients comfort, all right? And there's reduced requirement for heavy sedation and sometimes muscle paralysis. With this, it preserves speech, swallowing, and cough. So the patient can do all of this while on non-invasive ventilation. Like I mentioned, it avoids complications associated with endotracheal intubation. I'm sure you know Tinkerbed, all right? There are many of them. It also leads to reduced cost of care because of reduced equipment and manpower that is needed. And studies have shown that it also helps reduce the hospital length of stay. The disadvantages include slow, non-invasive ventilation may sometimes be slow to correct respiratory failure. It takes time. And there are, occasions for excessive air leakage, eye irritation, facial skin necrosis, okay? And for patients that if we are not careful, if we are not vigilant, there could be a loss of airway access and protection. And some patients are afraid of being confined in a space. And there's a need for supervision for patient. So these are some of the advantages and disadvantages that are associated with non-invasive ventilation. Okay, next. All right. So there are different modes of delivering non-invasive ventilation. The first one is what we know as CPAP that I'm sure we are all familiar with. The picture on the right side of the screen shows us a CPAP machine for the delivery of non-invasive ventilation. You can see the mask, the hair straps, and the nose that is connected to the CPAP machine. This is an example of a non-invasive ventilation. Okay, I'm trying to unmute people who are joining. Please, when you're joining, you can unmute yourself so that we don't get distracted. It's a long presentation today. Okay, so CPAP is a mode of delivering non-invasive ventilation. And CPAP, like we know, is a constant positive airway pressure that is delivered throughout the respiratory cycle. All right, and usually primary indication is for the treatment of hypoxemia. All right, when you have reduced PaO2 or SpO2. So it helps to improve oxygenation by maintaining constant airway pressure throughout both inspiration and expiration. And it also helps to decrease the word of breathing that the patient is doing because there's a supportive positive pressure that is being delivered by the CPAP machine. Like mnemonics, you can see the mnemonics. So if you're asked what are the indications for CPAP, all right, you just write CPAP and just put COPD, patients chronic obstructive pulmonary disease of chronic obstructive airway disease. All right, that's the first C. Patients who are in congestive cardiac failure will benefit from CPAP because it augments oxygenation and reduces work of breathing. That will not be good for patients who are in heart failure. Pneumonia patient because of their hypoxemia that they have, ARDS, acute respiratory distress syndrome, asthma, and patients with pulmonary edema. These are some of the indications for the application of CPAP for delivering non-invasive ventilation. Like I said, the picture is there. Just put the picture in your mind so that when you come across it, you know what it is. So the second mode of delivering ventilation is what we call the bilevel PAP, bilevel PAP, all right? Bilevel PAP, that is bilevel positive airway pressure. This is a combination of inspiratory positive airway pressure and expiratory positive airway pressure, all right? Unlike for CPAP, it is indicated for the management of both hypoxemia and hypercapnia. And we're going to look at the differences between CPAP and BiPAP in a little while. Because in BiPAP, you have both inspiratory positive air pressure and expiratory positive air pressure. Each of the components of BiPAP has its own functions and indications. For instance, in inspiratory positive air pressure, it decreases the patient's work of breathing, it increases spontaneous tidal volume, and at the end of the day, reduces spontaneous respiratory rate because of the support that is given during inspiration. For expiratory positive air pressure, this produces PEEP. All right, we know PEEP is positive end expiratory pressure to keep the distal alveoli open for improved oxygenation. It increases functional residual capacity, which is the lung volume that is present at the end of normal tidal breath. And at the end of the day, because it increases oxygenation by opening up the distal airway, it reduces the requirement for FiO2. For instance, a patient who is in hypoxemia or acute respiratory failure that would have required maybe 70 or 80% FiO2, with application of BiPAP with EPAP, you can have at least maybe about 30 to 40 FiO2, which also goes a long way to help prevent oxygen toxicity. Indications, they are similar to CPAP, acute respiratory failure. It could be type 1, type 2, which we covered in our last tutorial, COPD patient, and asthma. Now, the diagram on the right side of the slide kind of compares CPAP with BiPAP. with some subtle differences, all right, that we're going to look at. Let's try and mute our mics as we join. All right, so CPAP, you can look at this, stands for continuous positive airway pressure, while BPAP stands for bi-level positive airway pressure. In CPAP, for instance, if you are asked compare and contrast CPAP and BPAP, this is what you are asked. In CPAP, there's a single set of pressure throughout, the respiratory cycle. While for BPAP, two different distinct pressures are supplied both during inspiration and expiration. All right. CPAP is more affordable, while this other ones is more expensive. And you can see as we go on, you'll see that there are different pressure. The respiratory positive air pressure is usually more than the respiratory positive airway pressure. Okay. Now this is what we're talking about here. All right. The pressure during inspiration is about 12 centimeters of water, while the pressure during expiration is lower at about 8 centimeters of water. But for CPAP, the same pressure is maintained throughout the respiratory cycle. BPAP is expensive, like I mentioned before, and CPAP can actually be used at home. Patients who are discharged home can actually have CPAP, and CPAP machine can actually be a home appliance because it's less complicated to operate, and it's useful, especially in treating or managing acute hypoxemic respiratory failure. Now, for you to set up a non-invasive ventilation, number one, you need to ensure that there are no contraindications that we're going to look at very soon, because there are contraindications. It's not every patient who is in respiratory failure that is deemed suitable for non-invasive ventilation. So you want to rule out any contraindications, all right? Some of them is that the patient should be able to maintain his or her own airway, all right? And the patient should also be comfortable in enclosed space, because we are using an interface, which is your face mask or your oral nasal mask. All right, you want to commence oxygen therapy, all right? Usually you commence oxygen therapy at a high FiO2, which you gradually decrease in response to your ABG values or even your SpO2. So you need to explain your procedure. Like we said, the patient is not heavily sedated. The patient, most of them are awake or they are easily arousable. So you want to explain the procedure to your patient and give some form of reassurance. Then you select your appropriate mask size for the patient, set up your ventilator setting, make up your mind, does this patient require, or does the patient require BPAP? And what kind of machine do you have? Do you have a CPAP machine or BiPAP? Most hospitals have CPAP machine. Excuse me. You hold the mask in place where you want it, and you reassure the patient, and you fix the mask. Then you start your ventilation with regular monitoring and assessment of the patient's vitals. No, like I said, you need to rule out contraindications. Some of the contraindications to non-invasive ventilation is unconsciousness. Patients who has reduced consciousness, who are not able to protect their airway. All right, patients who have an unstable blood pressure, hypotensive. All right, patients with pneumothorax, patients with bowel obstruction, facial trauma, and excessive secretions. These are some of the common contraindications to non-invasive ventilation. So the three cardinal points in using it is this patient conscious? Is it cooperative? Does he obey command? Is the blood pressure stable? All right, or does this patient require inotropic support? And you need to also ensure that the patient is able to protect his airway in case there are occasions where there may be a loss of airway, and which you don't want in this group of patients. So monitoring during non-invasive ventilation is important. You need to continue your pulse oximetry. You want to monitor your tidal volume, all right? And like I said, for all the people that work with me, before you put a patient on any form of ventilation, you need to have a baseline ABG values. And then 1 hour after you put your patient on ventilator to ensure that your settings are correct, meeting the patient's need. And you need to be able to look at the patient, monitor the respiratory rate and chest wall movement, heart rate and blood pressure needs to be monitored. And your eye should be on the patient's mental state and GCS to ensure that the patient is conscious. This patient also making adequate respiratory effort. Do you need increased pressure to help the patient's tidal volume? And how comfortable is this patient? These are things you need to monitor during non-invasive ventilation. Now, there are times when you felt this patient will benefit from non-invasive ventilation, but there are certain parameters that would indicate that your treatment has failed. All right. Number one, if you observe any deterioration in the patient's condition, for instance, the patient who was awake begins to deep mental state in terms of level of consciousness. It shows that your non-invasive ventilation has failed or is not improving the patient's clinical status. And when you obtain your ABG and you're still having hypoxemia or you're having hypercapnia, and either your your pH is becoming more acidotic, you know that your NIV is not working. Intolerance, some patients cannot tolerate it, and there's no need of forcing a patient on a therapy that he cannot tolerate. Some of these patients may require conversion to invasive ventilation, putting an endotracheal tube and converting to invasive ventilation instead of just continue with a failed therapy. Okay, let me mute these guys. Okay, mute. Okay. Dr. Sampson, I can't mute you. Can you mute yourself? Okay. Okay, so we continue, and you want to ensure that your medical treatment is optimal. All right. For instance, patients who are pneumonic, you want to be sure that your antibiotics are optimal, and you want to treat complications. All right. So at that point, you need to decide: do I discontinue this therapy since it's not helping? So these are indices to criteria to discontinue non-invasive ventilation. Discuss with your specialist, consultant. This patient is not tolerating the mask. It's pulling it off. Maybe it's claustrophobic or whatever it is. It's not comfortable, and the gas exchange is not improving, and maybe the patient GCS is dropped. Patient becomes more hemodynamically unstable, and you have your ECG features of some arrhythmic or ischemic changes. Now, that is the point where you say you discontinue your non-invasive ventilatory mode and do something else. All right. It's not all bad. Sometimes you're able to achieve some clinical improvement, and this is evidenced by a reduction in your respiratory rate when you now have a stable respiratory rate less than 24 cycles per minute, heart rate is less than 110 per minute, and which is left from acidotic range to 7.35, and you can get an SpO2 of greater than 90% on 0.4% FR out of oxygen, especially for COPD patients and congestive cardiac failure patients. You want to say that if I can get these parameters, for 4 hours, at a stretch consistent, you may want to withdraw, all right, your non-invasive therapy. That shows, hooray, you have succeeded in helping this patient. All right, complications do arise from non-invasive ventilation, just like any other therapies. The patient can have hypoxia, all right? Barotrauma from, especially if you are using the CPAP and not BPAP, reduced cardiac output, all right? And sometimes the patient may vomit, and that may lead to aspiration because the airway is not protected. And pressure areas of the face where the interface, the mask and all that is applied. And sometimes some patients may have distended stomach. And these are some of the complications that may arise from non-invasive ventilation use. All right, if you do have any question, you can ask me before we go to ventilator waveforms. And ventilator waveform is important. I want to spend some time on this.
No show anywhere.
Senior man. Hello, sir. Good evening, sir.
Yeah, good evening, Dr.
Thank you for the presentation, sir. I just want you to, if there's any clarification on this, I just want you to let me shed more light on it. I know that in COPD patients, their problem is with the expiration. And I'm just being curious why we apply BiPAP with 2 different kind of pressure, both at the inspiratory and expiratory phase. And the pressure that we apply at the inspiratory is higher. And if the problem is with the expiratory, I think the higher pressure should be applied in order to mitigate this problem. I don't know why this is so.
Yeah,
I just want to ask if there is any explanation.
If I get your question well, because there's some background, I don't know where that background noise is coming from. But here, where you're saying that a COPD patient required more pressure at the EPAP, isn't it? Expiratory positive airway pressure than the inspiratory. Is that what you're saying? Dr. Odushade, did you hear me? Hello? Dr. Odushade, I can't hear you. Can you hear me? Are you saying that, are you asking why they need higher expiratory pressure? Oh my, did anybody get her question to help me?
Yes, Chief. Good evening, sir.
Good evening, my sister.
Yes, for the BiPAP, what she's asking is that for COPD patients whose major problem is expiratory, they retain CO2. And under the BiPAP you showed us, there's 12 for inspiration and 8 for expiration. So she's saying that she thought because their problem is expiration, that she would have thought they should need more pressure to expire. It should have been the reverse. That if she doesn't know if you can explain why we are using lesser pressure for expiration when we know that their problem is actually expiration, sir. Thank you, sir.
Yes, thank you. Thank you for explaining that. Now, we should, whatever therapies we're giving, we should always remember normal physiology. All right, normal physiology is that expiration is passive. All right, and what we're doing, especially if you look at PPAP also, we're trying to keep the distal alveoli open enough. And the reason why we're doing that is not just to give more time for expiration, all right, is to improve oxygenation. All right, we're trying to improve oxygenation. And the reason why we're given positive pressure during expiratory phase is to give more time for expiration for oxygen. All right. For us to, expiratory wise, the retention of CO2, we can give more time for expiration, because giving more pressure during the expiratory phase will cause more barotrauma, will cause more atelic trauma, because at the end of expiration, you really do not need positive pressure. But in order to improve oxygenation, what we're doing with COPD is to improve oxygenation and give more time for carbon dioxide. And don't forget that the oxygenation we're talking about, we're not achieving a PO2 as high as normal, because at that point, their respiratory drive is only responsive to hypoxemia. So in order to increase the respiratory output, you give them more time at expiration, not necessarily by increasing pressure during expiration. I don't know if you understand that. Giving pressure during expiration is basically to improve oxygenation and not to increase respiratory effort. Does it make sense?
Yes, it does. It does,
Yes.
Chief. So, thank you very much, Chief. That means that our IE ratio, instead of 1 to 2, we can actually do maybe 1 to 3.
Yes, 1 to 3. You give more time for expiration, but
yes,
not that you are increasing pressure at expiration.
All right.
The increased pressure at expiration is to improve oxygenation.
Thank you very much, Chief.
All right.
Thank you, sir.
Dr. Yetunde represent you well.
Yes, I'm actually on transit.
Oh, it
Thank
is well
you, sir.
with you.
Thank you, sir.
Where are you traveling to this night?
Lagos.
Ah, the Lord is your muzzle.
Yes, sir. Thank you, sir.
All right, safe trip.
Thank you, sir.
All right. So can we go on? Any other question on non-invasive ventilation? Okay, so let's talk about ventilator waveforms. I'm sure that those of us who have seen ventilators, who are familiar with ventilators, will also be familiar with some waveforms that are displayed even in our anesthetic machine in the theater, not necessarily in ICU alone. So ventilator waveforms are graphical representation of how your assisted breath is being delivered to the patient. All right, you see the waveforms on your ventilator interface. All right, and there are 3 different types of ventilation, 2 different types. Actually, we have what we call the scalar waveform and the loop waveform. The scalar waveform and the loop waveform. And the scalar waveform is actually a plot of either pressure, volume, or flow against time. In all of scalar waveforms, the time is always on the x-axis. While for the loop waveforms, plot of pressure, volume, or flow against each other. And this is a major difference between the 2 of them. So if you have a pressure versus time waveform, that is a scalar waveform. All right, so when you have volume versus time, is scalar waveform. Flow versus time is scalar. But when you have pressure versus volume, or volume versus flow, I know that those are loop waveform. And it's important for you to differentiate between these 2 types of waveforms on your ventilator. When we're training, we didn't have this privilege that we're having now to look at the ventilator waveforms, especially as it helps us to diagnose some of the problems that we may encounter in ventilating our patient. Okay, so this is a group of scalar waveforms. If I ask you, where is a scalar waveform, you can see the time on the x-axis. all right? And there are different types of scalar waveforms. We have the square waveforms, all right? We have the ascending ramp, or ascending pressure, or ascending volume, or ascending flow over time. We have the descending ramp, all right? As pressure reaches peak of volume reaches peak, it decreases during the inspiratory time. We have the sine waveform and the exponential and all that, exponential rising and exponential decay. So these are different types of scalar waveforms on your ventilator. So we have different types. We have the pressure waveforms, the flow waveforms, and volume waveforms. All right. Most of the times, the pressure waveforms are either square, like what we saw earlier on. All right, the square, or is exponential rise, or you can even have the sinusoidal. So the pressure waveforms come in 3 different formats. For the flow waveforms, because it's flow related, most of the time it comes in more waveforms. The descending ramp is the commonly used, especially for pressure support or pressure control ventilation. The square, this is constant pressure or constant flow throughout. We have exponential decay, which is very related to the descending ramp. And we have the sinusoidal. Volume waveforms are just 2 types. We have the ascending and the sinusoidal waveforms. Don't forget that sinusoidal waveforms are particularly seen in unsupported breathing. So when you see a sinusoidal waveforms, you need to know that this patient is having unsupported spontaneous breathing. All right, so scalar waveforms, we have, like I said, there are different types that I showed you before: the square, the ascending, the descending, and all that, you know. But for sake of single best answer questions, if you're asked for pressure control modes, the common waveforms that are usually seen are the decelerating or decay flow. That's for pressure control. What it means is that the machine gives increased maximum pressure, and as the respiratory cycle continues, the pressure decreases. So it's not a constant pressure throughout your respiratory cycle. So for pressure control, you give a high pressure and then the pressure declines over time or decays. So for pressure control, the type of waveform, especially when you're using flow versus time, you know, it's a decelerating or a decay flow you will get. For volume control modes, the flow waveform can change depending on the ventilator options you have. But for pressure control, it is set at decelerating because you want to avoid barotrauma. You don't want to give constant pressure, constant high pressure at a constant rate to the patient. Do you understand that? Now, these are types that I mentioned before. For the pressure, all right, it's always decelerating. It accelerates to this point and begins to go down. It's always decelerating, all right? For flow, this is square, all right? It's constant, and this is volume, all right? So for volume, like we said, for volume control, it changes depending on the ventilator mode or the ventilator type and the compliance of the patient's chest. But for pressure, it's always decelerating or decay type. All right, so this is it. You can see for the flow, it's always decelerating and all that. And this cannot be changed. The waveforms on pressure modes cannot be changed, unlike for the volume modes. Now, if you look at the square waveform, the inspiratory time is usually shortest, okay? The time for inspiration is shortest, and they have the highest peak inspiratory pressure. So for patients who are susceptible to barotrauma, or patients who, like ARDS patients that have friable or lung tissues, you don't want to use a square waveform for them. All right. So low mean inspiratory pressure, which is better, All right, that is why the inspiratory time is shortest. And the advantage is that they have low mean inspiratory pressures. So it allows for better venous return and cardiac output. And this maintains your blood pressure better. The only advantage there is the maintenance of your blood pressure. Otherwise, for patients who are susceptible to barrow arterial trauma, you don't want to use a square waveform. All right, the descending ramp form, all right, like I said, there's increased inspiratory time, all right, or the peak inspiratory flow time, and it decreases over time. In descending ramp, you have the least peak inspiratory pressure, so as much as 19% decrease compared to the square waveform. The idea is that you want to give high mean airway pressure, and it helps with lung inflation. And as the lung deflates, the pressure reduces, and it helps with oxygenation. So if you are comparing square waveforms and descending ramp form, one is better to maintain cardiac output. The other one is better for maintaining oxygenation, especially while reducing the risk for barrow trauma, arterial trauma. I hope it makes sense. All right, the sinusoidal, all right, or the sine waveforms, or the ascending one, all right, there's an initial flow rates which are slow, all right, but a lot of times when you have patient ventilator asynchrony, it is usually commoner with sinusoidal and ascending ramp flow, all right, and like I mentioned before, in sinusoidal waveform, it's only used, all right, so in patients who are being unsupported, all right, patients who are breathing spontaneously. And this mode should not be used when the patient is being assisted. All right, descending ramp that we mentioned before, especially for the waveform, usually preferred, and the initial flow rate makes the flow demand of the patient, decreases air hunger, and the pressure reduces as you go on. Okay, deceleration flow rate, flow waveform, I mentioned this before. It decreases peak inspiratory pressure, all right, therefore reducing the risk of barrow trauma. It decreases oxygenation, all right, which therefore reduces the oxygenation index. This is alveolar arterial oxygen delivery, okay, and it increases it. So the alveolar oxygenation, arterial oxygenation, that of alveolar oxygenation approximates very closely because it gives you increased flow, patient, especially lung inflation. And it also improves patient ventilator asynchrony, all right? It is more physiological because when you start breathing normally physiologically, you take a very high breath and the breath reduces as you begin to exhale. So it improves patient ventilator synchrony, as we're going to see as we go on. Disadvantage increases that it decreases expiratory time. So there's a potential for auto-PEEP, or what we call breath stacking, all right? If another breath accumulates before the previous one is fully expelled. So it's called auto-PEEP or breath stacking. They keep building on each other. And obviously that increases intrathoracic pressure and it affects your cardiac output. All right, that is what it means. And for patients who have the altered blood-brain barrier, all right, in traumatic brain injury or space-occupying lesions in the brain, this type of waveform tend to increase intracranial pressure. And if you need to use this, especially because of improved oxygenation that it gives you, the intracranial pressure must be constantly monitored. And you should have an intraventricular drain in order for you to quickly let out CSF to control your intracranial pressure. All right, so the expiratory flow waveform, don't forget, like I mentioned before, expiration is always passive, okay? And is determined by the compliance of the lung and the resistance of the airway. All right, don't forget that you need to look at the peak expiratory flow, the slope of the expiratory limb. What time are you giving to expiration? And you need to also ensure that the waveform reaches this baseline, that is, there is no auto PEEP or breast stacking for your patient, in your patient rather. Okay, so there are some informations you can get from your ventilator waveforms. Okay, tidal volume. When you want to look at tidal volume, ensure that the volume is on the y-axis. That is the only way you can get your tidal volume. And if there's air leak, okay, and the y-axis you want to is graduated, you want to see, is it 500 mil, is it 600 mil, or whatever it is usually graduated. So for you to compute your tidal volume, you look at the y-axis for time graph. For air leak, you see that the expiratory lip does not return to the s-axis, okay? Does not return, so there's air leak. When there's active expiration, you'd see that tracing continues beyond the baseline. And when the auto PEEP, like I mentioned before, the limb fails to return to the baseline. So when you see, and that's one of the diagnostic importance of ventilator waveforms, ability to see, oh, this expiratory limb is not returning to the baseline. Maybe this patient is building auto PEEP or there's breast stacking. But when the tracing goes beyond the baseline on the s-axis, there's active instead of passive expiration going on. So that is scalar waveforms that we've mentioned. Then we'll talk about the loop waveforms. Like I mentioned before, time is not considered here. There's a plot of either pressure volume or flow volume in loop waveforms. In pressure volume loop waveforms, the volume is plotted on the y-axis and the pressure is on the s-axis. Okay, the pressure is on the s-axis while the volume is on the y-axis. Here, the inspiratory curve is upward. You can see this is the inspiratory. Okay, it's moving. This is the inspiratory curve, all right, while the expiratory curve is downward. You can see that spontaneous breath go clockwise, while positive pressure breaths will go anti-clockwise. All right, the bottom of the s-axis is usually set at PEEP, all right? And if it's zero, all right, if it starts from zero, it means that there's no PEEP that is set at all. So if you see a ventilator waveform and it's starting from 0.0, that means that there's no PEEP. But here, it's starting at 5, so a PEEP of 5 is being applied to the patient here. Okay. Area to the right of an imaginary line drawn down the middle of the lobe represents the inspiratory resistance, and the area to the left represents expiratory resistance. And this is important for you to know whether there's increased resistance during inspiration or increased resistance during the expiration. All right, the flow volume looks like what you do for your pulmonary function test. All right, especially to determine your peak expiratory flow and all that, or peak inspiratory flow. Okay, now this is the flow is plotted on the y-axis and the volume on the s-axis. Usually similar to the ones we use for pulmonary function test, but note that this one is upside down, unlike the pulmonary function test, which is on the other side. The inspiration is above the horizontal line. Okay, you see my arrow. This is the inspiration, while expiration is below. All right, the shape of the inspiratory curve, you can see this is inspiration is usually set at what is on the ventilator. You can see this is 40 centimeters of water. All right, and the shape of the expiratory flow represents passive expiration, okay, and goes all the way. So in as much as it's similar, although it's upside down, you can actually use to determine your peak inspiratory flow or your peak expiratory flow, and it can also be used to determine your tidal volume in an ICU setting. All right, so how do you use these graphs to diagnose your disease state, especially during ventilation. These are some of the things we've mentioned before, just some additions to it. Okay, let me mute them. I think there's a family discussion going on. All right. So pressure time waveform, when you see increased difference between the peak pressure and the peak plateau, it shows that there's an increased airway resistance. If you're using the pressure time scalar waveform, when there's a difference beyond normal between the peak pressure and the peak plateau, it shows that there's increased resistance. And a lot of times, the peak plateau may also be normal, but there's an increase in peak pressure because of the resistance. The ventilator is trying to push to overcome the resistance. All right, for expiratory flow, you'll see that there's a decreased peak expiratory flow rate. All right, there's increased expiratory time. All right, especially in the COPD patients where there's increased resistance. And in this patient, there's a potential for auto-PEEP because you do not have the airway totally, devoid of air at that point in time. And sometimes you can have loss of peak, especially in cases with emphysema. All right, for patients who have decreased compliance of their airway, if you're looking at the pressure time waveform, you see that there's increased peak plateau and peak pressure. All right, and for total waveform, you'll see increased respiratory flow rate and shortened expiratory time. It shows you that there's reduced or decreased compliance of the lung in the patient. So the ventilator waveform is interesting if we can just interact more with it, especially in our ICU setting. Even during theater sessions for anesthetic machines that have ventilatory modes, all right, you will see a ventilator waveform. Just interact with it. And the more you interact with it, the more it will, you appreciate it better. Okay, any questions on waveforms before we go to auto-PEEP? Any question? Or we should fire on? Ajayi Oba from Ife, how are you? I hope you are the same person.
Good evening, sir.
Good evening, my brother. You are the one from Ife?
Yes, sir.
Yeah, I remember the name, okay. And it's from my former center, UITH, I guess. And Mokolo.
Yes, sir. Yes, sir.
Yes, yes. There's some people here.
Yes, sir.
So any question on ventilator waveforms, or we should just fire on? Dario Laoye, I know you.
No question, sir.
Okay, no question. Let's quickly, rattle. It's almost an hour. So let's look at auto-PEEP. Auto-PEEP or air trapping. So auto-PEEP is defined as a positive end expiratory pressure that is caused by the progressive accumulation of air, which is due to incomplete expiration prior to the initiation of the next breath. All right, so, and when there's incomplete, all right, expiration before the next breath is taken, you have what we call auto-PEEP. All right, and a lot of patients with emphysema, all right, have auto-PEEP, all right, and that's why a lot of times they pulse their lips because they have reduced time at expiration. So now the etiologies of auto-PEEP include insufficient expiratory time, which could be the fault of the operator. Maybe the time is insufficient, or you can have unstable alveoli that collapse before the air in it is fully expired. Now, you can notice an auto peep on your waveform. If you have a pressure waveform, you'll see that the waveform rises above the baseline during the expiratory hold. All right, it rises, it doesn't touch the baseline. It shows that yeah. All right. Okay. So if you are using a pressure waveform, you see that the waveform does not get to the baseline. All right, it's always above the baseline. If you are using flow wave, you see that the expiratory flow does not return to the baseline before the next breath is taken. And volume, you see that the expiratory portion of your volume wave does not return to the baseline. It shows that there's auto peep or breath stacking, as we say. So how do you manage auto peep? You want to change your ventilator setting, increase expiratory time, and decrease respiratory rate and tidal volume. Increase expiratory time. It could be minimal. You can just have 1 to 2.5 or 1 to 3 IE ratio. And you see that the waveform will just gradually fall to the baseline. You can also reduce the ventilatory demand of the patient, reduce respiratory demand by sedation. I don't like paralysis. I don't like paralyzing my patient in ICU. I can increase their sedation, but I'm also aware of the impact it will have on their blood pressure. But you reduce ventilatory demand so that the patient does not initiate breath before the end of expiration. All right, you can reduce flow resistance by using a larger sized endotracheal tube. You can change your endotracheal tube and regular suctioning to ensure that there is no secretion blocking the airway that is causing, and don't forget that expiration is passive. So a little amount of obstruction during expiration may lead to incomplete expiration. During inspiration, it may not be much of a problem because there's a positive pressure trying to break through whatever obstruction on the way. All right, bronchodilation, like your salbutamol, whatever it is that you use in your center, can actually help you to take care of auto PEEP. Sometimes you can actually give apply external PEEP, okay, by closing your what's it called, APL, okay, expiratory valve, and you give positive pressure. So it helps with, external PEEP, and that helps to evacuate the residual air in the alveoli. Okay, another thing you will definitely come across is this very popular terminology, what known as the patient ventilator asynchrony. All right, in colloquial parlance, we say the patient is fighting the ventilator. All right, or the patient is balking on the ventilator. The actual word is patient ventilator asynchrony. All right, sorry, I'm taking some water. Patient ventilator asynchrony, PVA. Okay, what does this mean? It means it occurs when the ventilator starts inspiration at the time the patient is also taking inspiration, at the time of the patient inspiration. So there's asynchrony. They're not working in tandem. The flow provided by the ventilator means the flow demand of the patient. Okay, sorry, this is ventilator synchrony. All right, they are working in tandem. Ventilator starts inspiration at the same time when the patient is ready for inspiration. That is ventilator synchrony. Okay, and at this point, whatever the patient is supported is meeting the demands of the patient. All right, so ventilator inspiratory time matches the patient's inspiratory time. That's when we say that there is a synchrony. And a lot of times, it may go unnoticed, patient ventilator is synchrony, and you need to be very careful. But because what you want is that your ventilator and the patients are working in tandem to meet what you have in mind. But when we talk about ventilator asynchrony, it's actually a mismatch between the patient and the ventilator, all right? And it occurs during time, flow, volume, or pressure, all right? At this time, they're not working together. The ventilator and the patient, there's a mismatch between them, all right? And it's a common phenomenon, like I said. It can be as high as 80% in all ventilated patients, or it can be as low as 10%, all right? And patient ventilator asynchrony could actually be due to patient factor, due to ventilator factor, or both, okay? A lot of times, the most common ventilator patient asynchrony are those that are related to triggering. When the patient triggers and, for breath, or the patient has insufficient effort, or the patient double triggers, all right? Initially, a lot of times, especially in assist mode, the patient triggers breath and the ventilator senses it and provides their needed support, all right? So the flow goes as one. But in ineffective triggering or double triggering, instead of triggering once, the patient triggers twice. So the ventilator senses it and provides flow twice, assists twice. And this may lead to a lot of mishap that we're going to look at it. All right, each of these types, you can actually detect them by looking at the flow or volume of pressure waveforms on your ventilator. There are a lot of unwanted outcomes of patient ventilator asynchrony. It can lead to patient discomfort, all right? I don't need you now. You're giving me what I don't need, And it can actually lead to difficulty with breathing. And a lot of times it leads to worsening pulmonary gas exchange, increases patient's work of breathing. It can lead to diaphragmatic injury, sleep impairment, which is a serious issue in the ICU. All right. And sometimes, because of that, inexperienced people in the ICU, once they see patient ventilator asynchrony, they either increase sedation or they paralyze the patient unnecessarily. But what you need to do when you are confronted with patient ventilator asynchrony is just adjust your mode of ventilation, control pain and anxiety. All right, and once you do that, because like we said, it could either be due to patient factor or ventilator factor. So if you deal with the patient factor, is the patient in pain, all right? Is the patient anxious? Is the patient feverish? Or is there any reason why this patient is auto-triggering or double triggering? You may want to find out, all right? And when you take care of patient's factor, you realize that you may not need too much of sedation, In fact, it's been said, avoid sedation, deep sedation as much as possible. There are specific ventilatory modes that assist in preventing or managing patient ventilator asynchrony. And like I mentioned before, proportional assist ventilation and neurally assisted ventilation are strategies that help to reduce patient ventilator asynchrony. All right, so I think we've come to the end. These are some references that you may want to, okay. Likely exam questions at the end also. For instance, which of the following ventilation mode does not support patient spontaneous breathing? Anybody want to try that? Which of the following ventilatory modes does not support patient spontaneous breathing? Anybody? 1 PSV, 2 SIMV, PCV, APRV, and CPAP. That will allow you.
C, pressure control.
Yeah, pressure control, correct.
C. Yes, sir.
Okay. All right, a 45-year-old female patient diagnosed COPD is being placed on non-invasive ventilator support. What are the contraindications to NIV support in this patient? What are the different types of CPAP that you know? Mention 5 indications for failure of treatment. And how do you know the criteria for discontinuing non-invasive ventilation in this patient? All right, these are common questions, all right, that go with this, okay? Yeah, I like this question. I asked my students the last time. A 52-year-old male patient is on mechanical ventilator following acute traumatic brain injury. He was, however, noticed to be breathing against the ventilator. 1, define patient ventilator asynchrony. 2, what are the likely causes of PVA? 5, what are the possible unwanted outcomes of PVA, and list how you will manage this patient. I don't want to hear increased sedation and paralysis. All right, so ladies and gentlemen, any questions, anything you want us to ventilate on before our time is gone?
Thank you very much.
Hello, sir.
Okay.
Okay.
My friend, Ramola, well done.
Good evening, ma. Well done, ma.
Okay. Who is talking first? Both of them have left for each other.
And as well be.
Okay, Dr. Dushote.
Sir.
Yes, any questions?
Yes, sir. I'm so sorry for the background noise.
No problem, no problem.
I just want to know if the platelet pressure can also be seen on the loop flow, because I only know that it can actually be depicted on the scalar waveform. And I want you to explain how we can easily pick it on the loop waveform.
Daramola, please explain what your sister just said.
Well,